shorter talk, so we start with the good news. As my colleague said, Dr. Safa, that atrial fibrillation is the most common arrhythmia, and systemic embolism is a major problem of that, and left atrial appendage is the most common site of thrombus formation. So we understand the problem. Anticoagulation, for sure, it's proven to reduce the risk of thromboembolism. However, sometimes it may be contraindicated. And then LA appendage exclusion developed, whether surgical or percutaneous. And we're going to talk mainly about Watchman device today because it's an FDA approved and it was mostly commonly used and studied. So it's a self-expanding nitinol cage. It was studied in the PROTECT atrial fibrillation 2009, then PREVAIL 2014, and then after extended follow-up in 2017, it was proved to be non-inferior to warfarin in preventing stroke, however, without the complication of bleeding and all that stuff. Then it was in 2015 approved by the FDA for a non-valvular atrial fibrillation and those patients who need anticoagulation and have a reason not to receive anticoagulation. Okay, so the protocol also, as Dr. Safa said, involves giving a short period of time some warfarin until endothelialization occur. It's 45 days post-implantation. Then you go to dual antiplatelet, usually aspirin and clopidogrel for 6 months, and then aspirin indefinitely. So we're going to speak about left atrial appendage anatomy. There is an orifice, neck and body and apex. This orifice is the anatomical orifice. It's different than the orifice we measure for a particular device. Okay, so also the anatomy, as just been mentioned, it can be a windsock, cactus, cauliflower, and chicken wing, and the commonest one is chicken wing. But because imagine chicken wing has a wide neck but a shallow depth, this will make it a little bit difficult for Watchman device. So it will push the Watchman device outside. Okay, so pre-closure, remember I'm talking about Watchman. These measurements are for the Watchman device. So you should image the appendage in all angles, starting 0, 45, 90, and 135. Then you measure, the maximal diameter of the landing zone. Now this is different orifice. It's not the anatomical orifice. This is for Watchman. So it's 2 centimeters below the pulmonary vein limbus, comedian ridge, ligament of Marshall, whatever you like to call it, but it's around 2 centimeters from here to here. And then the other side here, you see the circumflex artery. And this is, where you measure the landing zone. And which landing zone we take? We take the largest in all angles. Okay. Then you size your device accordingly. The device should be 8 to 20% larger than the landing zone, than the largest landing zone you have. Sometimes, there are contraindication or measurements that preclude LA appendage not suitable for Watchman device. Either too large orifice or too small. Too large is more than 30.4 or too small less than 16.8 millimeter, because there are no such devices suitable for these measurements. Also, if the depth is smaller than the largest LA orifice diameter, because most of the Watchman device will be outside the orifice. And if there is a secondary left atrial appendage lobe orifice that is less than 1 centimeter from the orifice. So if there is a secondary lobe, we like it to be deeper than 1 centimeter. Okay, so Dr. Hani also he did me a favor and he spoke about the puncture. The appendage is anterolateral, so you have to go infraposterior and push your wire so it will go to the anterolateral and land in the appendage. So either we do it by biplane transesophageal or 3D. In biplane, the image on the left is at 0 angle, The image on the right is at 90 degrees. So the right side, oops, let me go back. Okay, so the right is anterior of the left image, and left is posterior. At 90 degrees or bicaval, right is superior, and this is inferior. So we look at the tinting. The easiest way to do 3D. If you do a 3D and you know where is the best place for puncture is where the red arrow is. So you will guide the operator here. Sorry. Sometimes the wire will slip into the PFO, and then you maybe want the operator to withdraw it and try to puncture the septum in the correct position if he wants an easy procedure. Okay, so this is the device. He's trying to position the device in the left atrial appendage. This is not a good position, so he will pull it back. He will make sure that it is in the orifice, landing zone. So this is a good position device. You can see it. Now, it's ready for release. Before release, we have to do a few tests. It is the FASE criteria. We have to check for position. We have to check for the anchor, the size, and the seal. Position, by checking the protrusion. The device, the shoulder of the device, as showed here, should not protrude more than 40% of the device depth. In other words, 60% of the device should be below the landing zone. The anchor. So the operator will perform a tug test. He will pull the wire and let go. So he will check if the device position is stable, and it will stay where it should stay. So keep looking at what he's doing. You will see he's pulling the wire, and letting go. See? And very well anchored device. It's not moving at all. This is a little bit important about the sizing of the device. So because it's a circle, if you are looking at the device from above, it's a circle. So in order to in order to get the exact diameter of a circle, you have to cut it in the middle, in the center of the circle. So in that case, you have to see the metal attachment of the watchman device to do appropriate measurement, like the green line. But if you cut it, little bit off, like here in the red line, you will get different measurement, a smaller measurement than what you should get. So again, we measure in all angles after we see the metal attachment, like here. So this is the device diameter, and we measure it again in all angles, and we have to make sure that the compressed diameter or the device diameter that we measure is 8 to 20% lower than the device uncompressed diameter that is provided on the label of the device. And lastly is the seal. You look for any leakage. So again, you do it in all angles, and you do it at 0, 45, 90, and 135. Leakage like this, you have to measure the vena contracta, or the narrowest don't know what's happening. في حاجة بالزعتر. Okay. So it should be less than 5 millimeters. So anything less than 5 millimeters is accepted. Thank you. Oh my God. So now what do we do for a follow-up? So anticoagulation will continue until another transesophageal echo is done after 45 days. So if we have, again, I show you this all angles to tell you that we have to check at all angles. So we're checking 0, 45, 90, and 135, looking for everything, position and mainly for leakage. And if the paravalvular leak is less than 5 millimeter, it is acceptable, and we can that time stop the anticoagulation and just switch to dual antiplatelet. And thank you very much.
Thank you so much, Dr. Sami, for the second Yeah, thanks a lot. I'll just go quickly in the subject. I'll mainly focus on the 3D echo